algorithms matter for the patient's safety. When we follow a well-designed algorithms, we are less likely to forget key assessment or treatments like steroids, Dopplers, consent for possible hysterectomy. Studies show that a standardized algorithm in obstetrics lowers the variation in care, speed up the time critical processes like decision to incision, and they are associated with the better Apgars and fewer unnecessary cesarean sections. Learn Simply high-risk obstetrics algorithm. Topic is placental abruption. Suspect the diagnosis of placental abruption, perform a history and a physical examination, presence or absence of risk factors, confirm the gestational age, perform continuous fetal heart rate monitoring, contractions monitoring, and confirm the fetal well-being. Exclude other causes of antepartum hemorrhage. Perform an ultrasound to confirm the diagnosis. Is there active bleeding? Is the bleeding excessive or is the woman hemodynamically unstable? If bleeding is excessive and the patient is hemodynamically unstable, yes, then initiate the treatment without delay, admit to hospital, place 2 large bore IV lines, CBC, TNC, coagulation screen, urgent FFM, anesthesia consultation, fluid and blood product resuscitation. Consider immediate delivery regardless of the gestational age. But if the patient is not hemodynamically unstable, that initial management, admit to hospital, do the routine investigation, CBC, TNC, coagulation screen, IV access, active TNS, consider MFM, anesthesia consultation, fluid and blood product resuscitation. Further management depends on the gestational age. Then if previable is less than 24 weeks, consider outpatient management, regular prenatal visit, serial ultrasound examination, and amniotic fluid volume assessment. Trained underlying cause, manage hypertension, encourage cessation of smoking and cocaine abuse. If it is 24 to 36 weeks, continued expectant management, rest until the bleeding stops for less than 1 week. Inpatient care if bleeding, consider outpatient care if minimal and infrequent bleeding. IV access, active TNS at all the times in inpatient. Anesthesia, NICU, MFF consultation. Administer antenatal corticosteroids. Serial ultrasound examination. Consent for cesarean possible to need further surgery, sometimes hysterectomy and blood transfusion. If it's more than 36 weeks, proceed with delivery. Given the unpredictable nature of placental abruption, immediate delivery should be considered. Documentation of fetal lung maturity is not necessary. Consent for cesarean delivery and further hysterectomy and blood transfusion should be needed. So this is the full algorithm chart of placental abruption. So while doing the examination history, we should find that out. Then do the ultrasound, and bleeding is excessive. If you are dynamically unstable patient, then we have to treat immediately. If it's not, then the regular treatment, but initial treatment. And all the treatment will depend upon the gestational weeks. If it's less than 24 weeks, the treatment will be different. 24 to 36 weeks, and then more than 36 weeks, we should be worried about.